Afternoon. It's my pleasure to welcome you to the Alberta Wide Nursing Rounds. My name is Colleen Norris, and I am the Associate Dean of Research here at the Faculty of Nursing, and I'm going to be acting, well, sort of acting, because really Edie's the moderator for today's session, Dr. Pituskin. We are excited to continue our 2026 rounds, which are normally take place on the third Thursday of every month at noon. And thank you all for being here, so let's get started. Alberta Wide Nursing Rounds builds on the foundation of our long-standing citywide nursing rounds, which was an initiative that connected nurses, students, educators, and researchers here in Edmonton for many years, and now we're expanding our reach, or we're trying to. By going province-wide, we're creating spaces for nurses from all corners of Alberta, urban, rural, remote, to share knowledge, raise questions, and build community. This is about amplifying the voices of nurses and ensuring research and practice truly inform one another. These rounds are more than sharing findings. They're about tackling real-world issues that everyone faces in clinical practice and celebrating the impact of nursing scholarship. Before we begin this session, I would like to take a moment for a land acknowledgement. The Faculty of Nursing at the University of Alberta is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous people. I am fortunate to be involved in the women's health research, and specifically I think about Indigenous medicine women who lived and live on the lands across Alberta, and the vital roles they've played and are playing in their community, serving as healers, herbalists, and spiritual guides. We, especially me, have much to learn from them. They utilize traditional knowledge passed down through generations to treat various ailments using natural remedies, including plants, roots, and other substances. Their practices were and are deeply connected to cultural and spiritual beliefs of their community, emphasizing a holistic approach that considers the physical, emotional, spiritual well-being of individuals. And I am so grateful to be able to work and play on their lands. A quick housekeeping items before we begin. Today's session is being recorded, and I forgot to turn it on, Heather or Usha, so if you'd like to start recording it. And Dr. Edith Pituskin has been a colleague and a faculty member for a while now, and she's always worked in the cancer realm, of oncology realm. And actually, Edie was the one that got me going about nurse practitioners and their voice and how they are heard in our community. And she allowed me kindly to shadow her, and I learned so many things from shadowing Edie that day that I can't even thank her for enough for what I learned. But one of the things I learned was that from my perspective, and not knowing a lot about breast cancer, that Edie was quite clear that breast cancer has become a chronic disease. And I really liked looking at it from that perspective and how we, as women, look at it. And the other thing that I did was I decided to go back and do the certificate courses in the NP, just so that I could understand what NPs are doing and facing. Clearly, I'll never be able to be a clinician the way Edie is with her patients and the realm of experiences, including research, academic, and clinical, that she brings to practice. So I'll turn it over to my friend and colleague, Dr. Edith Pituskin.
And welcome, everybody. Oncology is an exciting place, and I hope that we can provide you some inspiration today from very new graduates to some of us who are 41 years in, and across different disciplines and stripes. So I'll start off and not waste any time introducing Dr. Hanne Ostergaard, who's a professor in the Department of Medical Microbiology and Immunology, and also the director of the Cancer Research Institute of Northern Alberta, CRINA. She'll introduce CRINA and the application of immunotherapy in cancer populations. Thank you, Hanne.
And thank you for inviting us and allowing us to present today. I'll say a few words about CRINA, or the Cancer Research Institute of Northern Alberta, and then talk a little bit about cancer immunotherapy. So, and next slide, please. So Cancer Research Institute of Northern Alberta, or CRINA as we like to call it, is a Pan-University of Alberta Research Institute, where we bring researchers together from all across campus and include the Cross Cancer Institute. We work very closely with Cancer Care Alberta, and our vision is to improve patient outcomes through cancer research. And our mission is to be a catalyst for cancer research and innovation, bringing together researchers, clinicians, and we use the term clinicians broadly. We want to include all kinds of clinicians, not just the medical oncologists. So we use that term very broadly. And also trainees, and trainees really participate very strongly in CRINA, and you'll be seeing one of our trainees presenting after me. And we want these individuals to work together to make impactful discoveries in cancer prevention, detection, treatment, and survivorship. Next slide, please. So this is taken right from our website, and this is really what we do. We have weekly seminars. We try to bring researchers together in Research Day, and we have other events. We fund some grants. We fund a number of studentships. And our main areas of research are trying to understand cancer. We have a number of people who really look for the biology of cancer and trying to identify vulnerabilities within these cancers that could be targeted for future treatment. We have a large number of individuals working on detecting cancer, and we feel this is really important because we know that if you detect cancer earlier and can get it at stage 1, stage 2, the outcomes are much better for patients. So this is a real focus, and this is being done in a number of different ways, using improved imaging, even developing the technology for imaging cancer, radionucleotide, radioligand detection using PET imaging. We have a number of people who are trying to detect circulating tumor DNA in the blood so that cancer could eventually be maybe caught with simple blood tests. And so I think that's a really important part of what we do. And then, of course, we develop new treatments for cancer. There have been drugs that have been developed that are going through clinical trials by members of CRINA, and new ones are being identified, often based on the vulnerabilities that were identified while trying to understand cancer. And then living better with cancer. We know that, there are a number of side effects that happen from the therapies that can be long-lasting. So those are being examined, and how to minimize those side effects from developing, or kind of help them help the patients living with those. There are also people are living longer with cancer. I don't know when we can call them cancer-free. It used to be 5 years. Now people are saying 10 years, but people are living for a lot longer after their treatment, and it's not always easy. There are a number of things that can be problematic going forward after your initial cancer journey, and we'll hear a bit more about that today. Next slide, please. So I'm also a cancer immunologist. I study the immune system, and I've spent my career trying to identify ways to target cancer using the immune system. Our immune system's fantastic at recognizing foreign antigens. Most everybody, if they get infected, they eventually get over that infection, and that's usually because of the contribution of the immune system. And unless you're very young and elderly, we're just our immune systems are in really good shape and able to do those kinds of things. Well, it turns out they're also able to recognize differences in tumor cells. Now, tumor cells are part of us, right? They're our own cells that have been mutated, but our immune systems are able to hone in on those mutations and respond to those mutations, and in some cases eliminate cancer. And tumors arise all the time, and our immune system is probably playing a very strong immunosurveillance role in keeping those small tumors from developing further in a healthy individual. Unfortunately, sometimes the immune system doesn't recognize those cancer cells as foreign and respond to them. So one area of therapy is trying to identify those unusual mutated portions of tumors and then using them as a vaccine to enhance the immune response. The other problem is that tumor cells can actually suppress the immune environment and suppress that response. So a number of researchers are trying different ways to harness that and prevent that from happening. Tumor cells can also become resistant to the immune system. They're constantly being mutated and changing, and sometimes they mutate in ways that completely ignore the immune system. They become invisible to the immune system. And so there are really many, many different approaches that are being used to enhance the immune response to cancer. I won't go through all of them, but there's a whole bunch of them, and they're collectively known as immunotherapy. Next slide. So one of the major cells that are responsible for immunotherapy are what's called CD8 T cells, or cytotoxic T lymphocytes, or CTL. And these are tumor cells that these CD8 T cells can recognize tumor cells, and they bind to them, kill them. And you can see at the bottom, you see a dead tumor cell. And these CD8 T cells are highly effective at doing this, and they can just kill over and over and over again. And so these are the cells that we really want to be active. Next slide, please. And we've known now for a number of years that if you have what are referred to as hot tumors, where you have a lot of CD8 T cells infiltrated into those tumors, your prognosis is generally pretty good, and you will for most cancers, have a better chance of responding to the tumor. If you have no cells, and sometimes the killer cells can only go up to the tumor and can't infiltrate those, or sometimes only a few cells can go in. Those are cold tumors, and usually doesn't offer a good prognosis for survival. So what we want to do as immunologists is really make more of these tumors hot. But what happens sometimes, next slide, please. These CD8 T cells become exhausted because they just get stimulated over and over again. And they express molecules on their cell surface that signal that they're exhausted. Next slide. And this is where checkpoint in therapy comes in. And many of you are familiar with checkpoint therapy, antibodies such as Yervoy and ipilimumab. They block these molecules on the cell surface that inhibit the responses, and then it reinvigorates them. Next slide, please. So now the CD8 T cells are able to respond. And one of the things is that in some cancers, up to 50% of patients can respond, but overall it's about 15 to 20% of patients respond. And we're really trying to understand, why is it that about 20% of patients respond to this and the other 80% don't? And that's a really active area of research. Next slide, please. The other thing is sometimes the CD8 T cells just are unable to recognize the tumor, as I mentioned earlier. And so what is being done is that these T cells are have another receptor added that does recognize the cancer cell. And these are called chimeric antigen receptors. And Angela will be talking a lot more about these in a few minutes here. And what this does, it makes many of the CD8 T cells in your body reactive to that tumor, and it can cause a very active response through a therapy called CAR T therapy. Next slide, please. And so with CAR T therapy, the T cells are collected from the patient, and then usually these CAR Ts are introduced through virus infection. And these are non-replicating viruses, so they don't cause an infection in the body. They just infect the T cells and then they're dead. They can't do anything else. But what they're able to do is introduce these CAR receptors into these T cells. These T cells are then cultured for a couple of weeks, and then the same individual is immunodepleted with using a few different approaches, and the T cells are injected back into them, and those now go and kill the cancer cells. But this is not without side effects, as we'll be hearing a lot more about today. The other thing is there are a lot of people trying to get away from the virus infection so that no virus is being introduced, and Angela will address that a bit more too. And so this therapy, when it works, is highly, highly effective. It can provide long-term, let's call them cures of individuals. They can live 10 years. They were first done in about 2011, and there are patients from that time that are still completely clear of cancer. So it's a great treatment, but it's not without its issues. And that's what we'll be looking at more today. Next slide, please. And just if you're interested in immunotherapy, I'll do a plug for CRINA here. We have a Science in the Cinema that will be done here in Edmonton at the Metro Cinema on May 5th. And it includes a panel of specialists, both immunologists and clinicians. And this is Jim Allison's breakthrough, and this is the discovery. Jim Allison received the Nobel Prize for the discovery of the first one of these checkpoint inhibitors that is now allowing a lot of people to live much longer and productive lives. And so I invite anybody to attend this. Next slide. With that, I'll thank you. And if you ever have any questions about CRINA or what we do, you can always email us at crina@ualberta.ca. Thank you.
Perfect. Thank you, Hannah. And I'll let Angela get herself set up as I introduce her. She completed her undergraduate degree in immunology and infection at the U of A and is now a master's student in Dr. Michael Chu's lab here at the U of A and Cross Cancer Institute. She will review the process of how CAR-based immunotherapy is possible with innovative U of A research that really is, well, cutting edge, and I'll let her explain that. Thank you.
Thank you so much. Are you able to see my screen? Okay, I'm going to try again.
We were able to see your screen, you just weren't in presenter mode.
Okay.
Here we go.
Is that working?
On the left, you should see presenter view. So beside custom show, you should see presenter view. Or from the beginning.
Okay, I can see presenter view from my side. Are you guys able to see my slides?
You can go ahead. We can see your slides. It'd just be a little bit smaller.
Oh, okay. I think I can do the other way.
Dandy.
Oh, that worked.
All right, can you see the full screen now?
No.
Sorry, I can't.
Should you want to drive?
Maybe. Okay. Well, sorry for the technical difficulties again. So my name is Angela. I am a master's student in Dr. Michael Chu's lab here at the University of Alberta. And today what I'm going to be talking about is some new advances in CAR T therapy. Specifically, I'll talk a little bit about what I do in the lab, which is working on natural, next generation CAR natural
A little
killer cells.
louder, please.
Okay. Hi, everyone. I'll just start over a little bit louder this time. My name is Angela. I'm a master's student in Dr. Michael Chu's lab here at the University of Alberta. And today what I'm going to be talking about is some advances in CAR T therapy, specifically talking about CAR natural killer cell, also known as NK cell therapy. Next slide, please. So we heard a lot from Dr. Ostergaard regarding what CAR T cell therapy is. I'd also like to highlight that this is not just being developed elsewhere, but it's actually happening here at the University of Alberta. So we have our own GMP grade Alberta cell manufacturing facility, and this is allowed for the production of CAR T cell therapies and really for this treatment to be a lot closer to patients. I'd also like to highlight some of the clinical trials that are happening at the Cross Cancer Institute that have been led by my supervisor, Dr. Michael Chu. Specifically, I'll highlight the first trial, the ACIT-1, which has shown really remarkable results of an 80% response rate and 60% long-term remission, highlighting how impactful this treatment is for patients. It is also going to be expanded to other provinces, and you can see the rest of the clinical trials on the screen, which are also targeting different types of cancers. Next slide, please. So I've just shown you all of the remarkable results and all of the clinical trials that we have going on with CAR T cell therapy. And these have been really great in changing the lives of many patients. However, there are still many challenges that remain associated with CAR T cell therapy. Specifically, there are some patients who receive CAR T cell therapy and develop severe side effects, including cytokine release syndrome and neurotoxicities. The FDA has also warned against risks of secondary T cell malignancies. As Dr. Ostergaard also previously mentioned, there are some concerns around the viral vector delivery portion, specifically concerns about insertional mutagenesis and a long, complex manufacturing process. Overall, CAR T cell therapy is also a costly and time-consuming process, and this can really limit accessibility for many patients. Next slide, please. So the question now becomes, what can we do to build upon the successes of CAR T cell therapy while still addressing some of the limitations and challenges that we have associated with it? And for a lot of researchers, the answer has become natural killer cells. These are also known as NK cells. These are a type of innate immune cells that have similar cytotoxic abilities as T cells. However, they do not carry the same severe side effects, specifically when I'm talking about cytokine release syndrome, neurotoxicities, or graft versus host disease. We don't really see those in natural killer cells as we do in T cells. Furthermore, natural killer cells are also innate immune cells. So they possess a dual action killing, meaning when they're engineered with the CAR, not only can they kill through that CAR receptor, but they also have their own innate natural killing mechanisms, making them inherently more resistant to antigen escape, which is something we oftentimes see with CAR T cell therapy. Finally, NK cells have a major advantage over T cells in the fact that they do not have to be patient matched, meaning that they can be collected and stored from a healthy donor and cryopreserved, allowing them to be used as an off-the-shelf therapy, which can largely reduce the production time. Next slide, please. Now, building on this concept of CAR-NK therapy, we have also been looking into other ways to genetically modify these cells to express this CAR receptor without using the viral vector delivery method. And for us in the lab, one method we have been exploring is the use of lipid nanoparticles. Now you can see in the figure in the middle of the slide, the schematic of a lipid nanoparticle. These are essentially tiny carriers that encode genetic instructions, in our case mRNA, that encodes for the CAR protein. Essentially how this would work is that these would be uptaken by the cell, where then the CAR protein can be produced and trafficked onto the cell surface, and that CAR will then be able to recognize and kill cancer cells. Now, I just have an animation that will pop up. This concept might actually sound familiar to quite a few of you because it is the same technology that has been used in the COVID mRNA vaccines. I had an animation. I'm not sure if it's going to click on it. There we go. Thank you. So this is actually the same platform that was used in the COVID mRNA vaccines, where they had their own lipid nanoparticle that encoded for a protein that allowed us to train our immune system against COVID. However, in our case, the mRNA that we're using will encode for the CAR protein, and this will allow the natural killer cells to then express that protein and kill the cancer cells. Next slide, please. So I just want to briefly go over some of the work that we've been able to do in the lab so far based off of this lipid nanoparticle CAR-NK platform. So what we've been able to do is successfully modify these natural killer cells to express the CAR protein. And we're specifically trying to target multiple myeloma by making CARs that target BCMA. BCMA is a protein that is highly expressed on these multiple myeloma cells, so it allows us to efficiently target them. Now, on the figure on the right-hand side over here, you will see a bunch of green dots. Those green dots represent our myeloma cancer cells. The row on the very top of that figure on the right-hand side shows our control NK cells. These are cells that are not expressing the CAR. On the bottom row, this shows our CAR NK cells. These are natural killer cells that express our CAR that target the BCMA protein that is present on multiple myeloma cells. And what you'll be able to see is that the CAR NK cells are more efficient at killing off those green cancer cells compared to our control NK cells that do not have the CAR. This is also reflected on the graph on the left-hand side, where you will be able to see that the blue line, which represents our CAR NK cells that target BCMA, have higher killing than the red line, which shows our natural killer cells that do not have the CAR. So ultimately, what this is showing is that our CAR NK cells are actually able to enhance killing of multiple myeloma cells by targeting the protein BCMA on multiple myeloma, meaning that it is a promising platform to be continuously studied. Next slide, please. So I'm going to briefly just go over what this would look like as a proposed CAR-NK workflow in the clinic. So it would essentially start by the collection of healthy donor blood collection, from which natural killer cells can be isolated and expanded. The next is the off-the-shelf portion. This would essentially mean cryopreservation or banking of those NK cells. And then when needed for a patient, these can essentially be genetically modified with the lipid nanoparticle in order to produce the CAR, which can then be delivered to the patient to initiate killing. Next slide, please. Ultimately, this matters because we know immunotherapy has the potential to impact a wide variety of patients. However, we are still seeing limitations in the safety and in the accessibility. And so it's important that we are taking steps to try to produce safer treatments which have faster access per patient, meaning that more patients can benefit from immunotherapy. And next slide, please. So I'd like to thank my supervisor, Dr. Michael Chu, as well as everybody in the lab who has contributed to this project and our collaborators and funding sources. Thank you so much.
Awesome. Thank you, Angela. Now, for something sort of different, really quite excited to introduce Nan Cox-Kennett, who's a nurse practitioner and team lead of cellular therapies, who will discuss eligibility for such treatments and common side effects during the acute recovery phase. And newly minted CJ Kennett will be speaking about the essential monitoring associated with receiving these important cellular therapies.
Awesome. Hi, everybody. I think you guys can see the slides because we've got two laptops set up so we can kind of do this together. So basically, I want to just reorientate you to where we're talking about in terms of cellular targets. We're going to specifically talk about the commercially available CAR-Ts that are available for use right now. And so this is a T cell that has been genetically engineered to target the first little red box at the top is CD19 expression. And so these are going to target immature B cells, and these would be the things that contribute to precursor B-cell leukemia. And then there are now, of course, BCMA targets that was just previously discussed, and these are found more on a plasma cell or myeloma cell. So these have been in use now for quite some time. But I want to just mention that while we're currently using this in malignancies that are hematologically based and lymphoma based, there are other targets that are being explored for solid tumors. And so this is why we wanted to sort of highlight this in this rounds, that this is potentially coming to a cancer center near you. There are cranial targets, thoracic targets, abdominal and pelvic targets, skin and soft tissue targets. The challenge in these groups has been to find a target that does not also exist on healthy cells, so that you're not causing toxicity, and also to find a way for these cells to live long enough to actually accomplish the job they've been asked to do. So when it comes to the commercially available cells, one of my roles within the center is helping our team to decide patient eligibility. So first off, you're making sure the patient has the appropriate cell target. So they do have CD19 expressed on their cancer, or this BCMA or CD138, which are the myeloma targets. They have to be fit. So you can't be bedridden. So the same kind of rule that applies to most other cancer therapies, we're going to make you sick before we make you well. And so we need to make sure you can survive that. And you have to be free from infection, including screening with a nasopharyngeal swab, dental review, because infection will also increase the toxicity. We screen heart, lungs, and blood work. And we also do a baseline MOCA for cognitive testing. And I'll let CJ explain a little bit more about that. Disease control, the larger the disease burden, the greater the cell kill, and therefore the greater the risk of toxicity. I want you to imagine that when we infuse these T cells, instead of getting a small response, because I've got a stuffy nose, I've got T cells that are going to start to respond to my stuffy nose, and then they gradually increase over time to help me recover from that. We're giving this big bolus dose of T cells, and so therefore there's going to be a lot of toxicity in terms of cell kill right off the bat. And that's something that we have to monitor for and prevent. We also require caregiver support full-time for a minimum of 30 days and 8 weeks preferred. And this is actually a huge burden for a lot of patients, especially when they're from a distance. And then they're required to live within 1 hour of Edmonton for 30 days as well, and up to 8 weeks. So the process, you've confirmed their disease, we collect their T cells, we send those cells off for production with people like our previous speaker. And while they're off, we give them bridging therapy. This may include chemotherapy or radiation to try to reduce their disease burden. And then just before we infuse the CAR T cells, we want to reduce the patient's own lymphocytes so that they're not going to kill these new ones that are coming in. And so we do give some lymphodepleting chemotherapy, and then we infuse the cells, and the patient remains in hospital and are discharged within 7 to 14 days. And then they're in a period of routine follow-up until at least day 30, often longer than that, before they can move into long-term follow-up. The initial time in hospital, we're watching for the acute side effects, which includes cytokine release syndrome. So all those T cells are going off killing the cancer, and then as they're killing the cancer, there's all these things like interleukin, interferon that are released, different types of interleukin like IL-6, IL-1. And these are basically saying, hey guys, the cancer's over here, come this way, come this way. So it's all these messages about where to come and do your thing. But those cytokines can also cause all kinds of toxicity in terms of fever, tachycardia, hypotension, capillary leak syndrome, some neurotoxicity, and organ dysfunction if that becomes out of control. So the timing of cytokine release is usually in the first 1 to 14 days post-infusion. And this correlates, you can see the time the T cells have infused, then there's this big spike in CRS that coincides with the number of T cells that are circulating within the peripheral blood as the cells have expanded and continue to grow before they eventually die off. This second hump here is something called ICANS, which stands for neurologic dysfunction that can happen. And we'll talk about that in a sec. And this can all progress to multi-organ dysfunction, or HLH, hemophagocytic lymphohistiocytosis. Basically, histiocytes start to chew up the patient's own tissues, which can be fatal. This can be very hard to distinguish from the fever of infection, and so it requires careful monitoring and skilled monitoring in a center that does this routinely. Oops. When I talk about ICANS, this is the immune effector cell associated neurotoxicity syndrome, big mouthful, so we'll shorten it to ICANS. As the cells move into systemic circulation and CSF, we know that this correlates with higher levels of cytokines, but the pathophysiology is not really clear. The onset can be 3 to 4 weeks, or rarely up to 6 to 9 months post-infusion. And if you've had ICANS early, you can actually have it late, so we can treat it. And then as there is further toxicity or more cytokines released, it can actually rebound. And so it's important to monitor not just once, but throughout the entire process. Can we predict the toxicity of CAR-T? So there's some scoring systems that are out there. That this one is called CAR Hematox, looking at neutrophils, hemoglobin, platelets, CRP, and ferritin. And you score the patient into low or high. And this can predict neutropenia. The higher the score, the worse the neutropenia, 14 days. The higher the score, the worse the complications for infection, non-relapse mortality, and survival is even impacted. So the more inflammatory you are before we start treatment, the worse it is. Here at our center, we use something called the Inflamix score, which groups into clusters. So you're either deemed inflammatory or not inflammatory. And it takes into consider as few as 6 values: hemoglobin, albumin, LD, CRP, ALK phos, livers, AST. We don't have access to IL-6, IL-10, or TNF, but we can do a D-dimer, ferritin, bilirubin, platelet, sub-USP. So we put in as many of those numbers as we can. It will come off with the are you inflammatory or not. And you can see here on the left, or sorry, right, the top scores for diffuse large B-cell lymphoma. This first graph is for progression-free survival. And you can see that if you're non-inflammatory, you do much better. And the second score is for overall survival. And so it's very important that we try to get the patient into a non-inflammatory state when you look at the difference in those curves. The same with follicular and mantle cell lymphoma, progression-free survival on the left, overall survival on the right. Again, the more we can get you into that non-inflammatory marker, the better you're going to do overall. What's the real-world incidence of CRS and ICANS across products? I could throw up clinical trial data, but I don't think that's very relevant because those are the premium patients. When it comes to real-world patients, depending on the CAR-T product, there's going to be various rates of CRS. But the most important part is this grade 3 CRS. This is the stuff that sends you to ICU. And you can see that those numbers are relatively low. And then any rates of ICANS, this neurologic toxicity, it's actually still pretty high. Interestingly, this lab that our previous speaker just talked about can construct for us on our homegrown CAR-T cells at a fraction, 1/10 of the cost of the cells that are available commercially, and had a lower rate of CRS, no rates of grade 3 CRS, and a very much less than half the commercial products in terms of grade 3 ICANS as well. Another thing we can do is geriatric assessment prior to CAR-T. I wish we were doing this, and I hope that we're going to be able to convince our team to start doing this soon. This clinical group looked at 61 patients, looking at time to get up and go, walk test, grip strength, nutrition, cognition, and biomarkers. And of those 61 patients, 13 were told they should not be transplanted based on functional, nutritional status, cognitive impairment, lack of caregiver support, uncontrolled depression, infection, or other comorbidities. You can notice 752,116 adds up to more than 13. It's because most of these patients had multiple comorbidities. So of those 13 patients that were told not to do it, they all went ahead and did it anyway. And this is their outcomes. The blue line here is the patients who decided to proceed in terms of probability of survival. for CD19 directed CAR T. So this is all any patients with lymphoma or acute lymphocytic leukemia. And the bottom lines are patients who had multiple myeloma getting this BCMA targeted therapy. So we do have a role here in trying to select the safest patients, and nursing can be a part of that. Cytopenias is an acute early problem as well. In all of the clinical trials, there's anemia, thrombocytopenia, neutropenia. And I think the most important thing is to look at this bottom row, prolonged, persistent thrombocytopenia, neutropenia. These patients are getting growth factors for like GCSF or thrombopoietin to try to boost their numbers, and yet they're still having this long-term risk for infection because of the neutropenia and bleeding risk with thrombocytopenia. Low fibrinogen can also require replacement, and that's linked to that risk for that HLH syndrome. Some of this also contributes, and risk is associated with this CAR T off-target effects. So at the top here is our malignant cell with the CD19 marker. Here's our CAR T. It's going to recognize that, but it's also going to recognize this naive B cell and this memory B cell and this plasma cell that also have CD19 on it. And so all of those are also going to be wiped out, which contributes to our infection risk, bacteremia, C. diff, pneumonia, worse in the first 30 days. But HSV, VZV, so these patients need Valtrex prophylaxis for shingles. Respiratory viruses, if we can vaccinate them before, but this is going to be an ongoing risk. And then because of the prolonged neutropenia and the potentially use of high-dose steroids to manage CRS syndrome, there's going to be risks for fungal infections, candida, aspergillosis, pneumocystis. And so we want to consider prophylaxis for these patients. And this would be part of the things that we would expect. And this comes with financial toxicity. Financial prophylaxis medications are not cheap. And so making sure that our patients have access to healthcare coverage, that they've got some form of insurance is important. I'm now going to hand it off to CJ to talk about the inpatient stuff.
Okay, can everyone hear me?
Speak up.
Yes, no, maybe so.
You bet.
Okay. All right. I will try to talk slowly because I've been told I talk very quickly. So if anyone needs to interrupt at a time to tell me to slow down, please do tell me. So we're first going to start with CRS. As Nan already mentioned, this is essentially the overacting of our immune system. To give you a visual, as you can see, I want you to imagine those hand sensor taps in public washrooms. Usually we swipe our hand underneath, it runs for a few seconds, and then it turns off, right? But here we're swiping our hand underneath and a geyser is coming out, and we're waiting and we're waiting and we're waiting, and it doesn't turn off. And eventually we're going to start having that flood come in. So we need to start looking for damage when we have that flood, as everyone knows when we have a flood. So now in terms of CRS, this damage will often look as though we're fighting an infection. We're having fever, general feeling of unwell, tachycardia, low blood pressure, shortness of breath, and tachypnea. Most cases are mild, but some can become severe or even life-threatening if not recognized early. Just give me 1 second here. So severe cases can involve fever, hypotension, and then progress to vasopressin requiring circulatory shock, vascular leakage, disseminated intravascular coagulation, or also known as DIC, and a multi-organ failure. In addition to this, respiratory systems are quite common in these patients, mild being cough, some tachypnea, but may progress to acute respiratory distress syndrome, so that's ARDS, with dyspnea, hypoxemia, and we can see bilateral opacities on chest x-rays. At the bedside, this may be mistaken for sepsis or vice versa. And this is why infection workup is crucial with that initial fever so we can rule out the underlying cause. This presentation, again, safe for sepsis, is very similar to the initial presentation of CRS. We need to do proper investigation to figure out what the underlying cause of, if it is actually CRS or otherwise. So as we can see in sepsis, patients can present with a wide range of symptoms, which can overlap. So we have the temperature of 37.5 or above. So when we get that, we begin to monitor more closely. We're rechecking that temperature within the hour. We're going to start considering early supportive measures, such as removing excess layers because our patients tend to bundle up. And then once we start reaching those higher levels, we're going to start doing our infectious workup. Sepsis is not the only condition that CRS can be mistaken for. It may be mistaken for cardiogenic shock, venous thromboembolism, alveolar hemorrhage, and even tumor lysis syndrome. So on this slide, I have the ASTC grading system here on the right. I personally prefer this chart as it includes general management for each grading system. As you can see here on the left, I've made a very brief list view of what we can find on the Alberta Bone Marrow and Blood Transplant Program practice manual directions for management. Again, this is a very simplified view, and I do encourage you to look into that yourself if you'd like. So we need to think of grading CRS as a routine assessment that we need to complete during our shifts. The grading of CRS highly impacts our thoughts on treatment escalation and whether transfer to another more acute facility or unit is necessary. So in grade 1, we're dealing with essentially just that fever. But then we get to grade 2, we're dealing with fever and either hypotension, it's not to the point of requiring vasopressors, or we're having the opposite if we're having well, not the opposite, but we're having a requirement of low flow oxygen instead. So at this point, we need to start considering escalation to a more acute facility or unit for the higher risk patients. And we begin to deal with more prolonged grade 2 or even higher grades, usually this is when practitioners start considering ICU transfer. The key point is that grading reflects escalation of treatment, as it also reflects the escalating systemic involvement, particularly with we're dealing with cardiovascular and respiratory concerns right here. Okay. So as the nurse, as you can see on the screen, this is generally what our parameters are going to be, give or take a little bit of a difference because everyone orders them differently. A key nursing consideration is baseline physiology. For example, if a patient is chronically hypotensive or is just generally low blood pressure at baseline, but they're asymptomatic, we need to interpret hypotension in context rather than in isolation. It is also important to ensure that that baseline parameter has been communicated clearly across the entire team, as this will then direct the escalation later on. There is no official grading system programmed into Connect Care. So if you're not familiar with this, it makes it quite hard to be able to go back to and reference it. So usually having a printout is really useful on units. It's important on discharge that the patient has letters to present to the ED team and that the Connect Care chart has been flagged as I'm receiving cellular treatment. And patients will also have daily follow-up post-discharge, and then this will decrease in frequency as they get further and further away from their cellular infusion date. We, as nurses, need to ensure that the patient has all the contact information if there is any emergency questions, and we also need to make sure that they're aware of which site they need to go to if they do have symptoms later on. So now we're going to go on to ICANS. We mainly focus, so with ICANS, we're again mainly focusing on the neurological and cerebellar assessments alongside neurological observations. This neurotoxicity is not thought to be a direct attack of CAR T cells on the brain itself, but rather an indirect effect of the systemic immune activation affecting the central nervous system. Patients can present with a wide range of symptoms, as you can see here on the slide. In more severe cases, this can progress to seizures, reduced level of consciousness, focal weakness, or signs suggestive of increased intracranial pressure or cerebral edema. One of the challenges with ICANS is that early symptoms can be subtle and may be easily missed if the patient's baseline is not well known. For example, mild confusion or slowed responses may be mistakenly attributed to age or baseline cognitive status if you're not familiar with the patient beforehand. This is why baseline assessments and ongoing comparison are so important, and consistency in nursing assignment as well. As was mentioned earlier by Nan, the involvement of a caretaker is also crucial, as this neurotoxicity may occur in the domestic setting after discharge. Caretaker may already know what the patient is like prior to the infusion and possibly right after the infusion if they're involved early enough. So they may be able to identify minor changes that we as health professionals can't. Furthermore, if English isn't our patient's first language, they're very good as translators if necessary. An early indicator of ICANS can be changes in writing ability. As part of a routine monitoring, patients are asked to complete a writing assessment, and this is usually happening when we're doing the vitals for CRS. This writing assessment is part of the ICE tool, which we'll go over in the next slide. And this helps identify subtle cognitive changes that might not be obvious during our conversation alone. So So the ICE tool is a general neurotoxicity tool that we use in oncology assessments for, well, of course, neurotoxicity. Thankfully, this is available in Connect Care, making charting on this so much easier. The assessment includes orientation, naming objects, counting backwards from 100 by 10, writing, and the patient's ability to follow commands. Personally, I don't ask them to follow an additional command than what I've already asked them to do during the assessment, unless I do have a concern like a delayed response time, because otherwise it's just takes up their time as well as mine. So additionally, some of these patients are going to be staying a little bit longer than our average patients receiving other therapies. And you'd think that after being asked the same question at least 3 times a day that they would start to memorize some things, specifically the naming of objects one. They'll just list the same 3 objects all the time. So sometimes I would say changing it up, like doing things like I spy, you describe something and the patient has to name it to you, can also work as well. So we already talked about the writing portion. The standard sentence used is the leaf on the Canadian flag is red. Very simple, very generic. It is true, right? So it makes it a little bit easier for people to remember. And that then reflects then if English is not their first language, we usually make them have a sentence that means a lot to them or it's very simplified. So that way it always sticks with them and it's easier for them to remember. So these sheets of paper that we have them write on are usually kept in the patient's room. It usually has about like 10 areas for them to write on. So that way the nurse can see the progression in the room. And if there is a concern, we usually want to take a snapshot of those trends and send it into the practitioner to see what's going on. And when that sheet's completed, we just scan it into their chart. Before treatment, of course, we need to do a baseline of this assessment because we're going to be comparing all the other ones to that one. Overall, ICANN severity is not determined by the ICE score alone. We also take into account other neurological changes, such as level of consciousness, seizures, new headaches, and other clinical indicators of neurological dysfunction. It's a combination of these findings that guides overall assessment and severity. As we just discussed how we assess the early neurological changes. Next step is actually understanding how these changes are identified. So once ICANS is suspected, treatment is based on how severe the symptoms are, hence the grading system. With grade 1, patients are awake, interactive, but may have subtle cognitive changes such as difficulty writing, word finding, or mild confusion. Management includes aspiration, precautions, NPO until we deem them safe, a swallow study, medications are changed to IV, and we're avoiding sedating medications as increased intracranial pressure and everything like that. We can give them some steroids and some anti-epileptics as a prophylaxis, and then further investigations such as imaging will be pursued and ordered by the provider. With grade 2, symptoms are more noticeable and the patient may need more prompting or will show a significant drop in that ICE score that we were talking about. The management of this is going to be supportive measures, again, closer monitoring, frequent dexamethasone, so this can be up to like 10 milligrams IV every 6 to 12 hours. And then again, an anti-epileptic, we're going to want to start that. If CRS is also present, we're going to want to start tocilizumab, and we can taper the steroids once they're stable. As with CRS, prolonged grade 2 or higher, practitioners may begin considering, if they're at a prolonged grade 2, or if they're higher, we're going to again want to consider sending them to ICU. But the most important takeaway is that subtle changes can progress quickly, so recognizing symptoms early, preparing in advance, and responding based on the grade is essential. To reduce CNS toxicity, seizure prevention is used. So this can be Keppra. And when CRS and ICANS is suspected, steroids can be ordered. However, steroids can reduce the effectiveness of CAR-T. Therefore, it should never be given without the express instructions of the CAR-T physician. So what we can do to reduce the flow of cytokines from the fire hose. So we can give them cytokine dampeners. So this will be interleukin blockers, and this can be anakinra and tocilizumab. Essentially, they can be given. They're going to help block that response from happening. So interestingly enough, there was a study done here at the Cross about giving a prophylactic IV anakinra, and it did it just showed a decrease in the rate of ICANS. Again, the same thing for disease progression for both study of those that got anacrina and those that didn't. But overall, we did see a positive effect. The only negatives really just being them having to get anakinra again at a later date, and just the general increase in costs. So,
So the other thing to consider is that, remember, we've blocked out all of these antibody-producing cells as well as the tumor cells. And so IgG, immune globulin that's produced by plasma cells, is also going to be significantly reduced. And so we do have criteria that if the levels dip below 4 grams per liter, that we go ahead and start prophylactic immune globulin therapy. This can be given either hospital-based or subcutaneous, and the patient is taught how to do it at home. There's a cost saving to that with less infusion time, less chair time in the center. However, there is quite a delay here anyway to get patients signed up for home infusion, because this is now overwhelming the system. In terms of the number of patients that are being referred, which has never happened before. The other thing you will have is that we've wiped out all of their memory B cells as well. So there's no awareness of past vaccinations. And so we have to consider vaccination after after cellular therapy. There currently is no standardized guidelines. There's a paucity of data about what vaccinations remain and what are completely wiped out. But at a very minimum, what's currently recommended is to go ahead and mimic the allogeneic stem cell transplant guidelines for post-immunization. We go ahead with non-lives at 6 months, but we have to consider immune reconstitution before we can give live vaccines. And so we have to test for CD4 levels and CD19 or 20 levels to make sure that there's actually enough cells to respond to those vaccines. And that's our conclusion of toxicities.
Very exciting, and you can see just how complex and complicated and important these treatments are. Maybe I will ask Colleen and Heather, would you prefer we wrap up, or would you prefer me just give 5-minute overview of my research? I mean, it will be recorded for people to see. What would you prefer?
That sounds fine, and if people have to go, that's fine, but it would be great to have it, Edie.
Okay, we can do that. I have cut slides, so that's okay. Okay, there we go. Is it visible?
It is, but we're seeing your presenter. There, perfect.
Yep, good. I'll get that out of the way. So Nan spoke of kind of some, I guess, ways to screen people who might be at risk for ICANS or any other severe toxicities. And when I saw these papers, they're not from our group, but this really kind of tweaked my interest, because this is the area of interest of my research program in terms of body composition, fat, and muscle redistribution, which seems to happen. Not only is it predictive of toxicity, but certainly cancer-specific outcomes in terms of progression-free survival and overall survival. So I was fortunate to be successful in funding opportunity from the Leukemia and Lymphoma Society of Canada, looking at supportive care given the prehab wherever possible, with collaboration from the Jim Pattison Heart Health Center, and with their staff and with my research team, offering them both in-person and virtual support before, during, where possible, and certainly in the recovery phase. And as you heard from Nan and CJ, these people can be profoundly ill. So my research program uses a lot of MRI imaging. Again, any organ in the body can be affected. So our team does whole body scanning of major organs. We started with the heart, but we're very interested in looking at whole body of evolution, so we can better understand, are there certain areas at risk? A lot of research work has focused on the L3 region, but we're also focusing on the legs. And why the legs? Because that's your means of locomotion. So we're really taking a whole body look to it. Now, Dan spoke about functional ability. So 6-minute walk test is something that you would do in a very frail population. But with my new precision health research lab, I have portable technology where we can measure expired gases and see how people are adjusting and recovering from exercise. And that black patch is attached to the calf where we can look at muscle oxygenation and recovery. And why is this is important? We did a quick review of the first 11 patients. So this is before CAR T or allo or auto transplant. And it's interesting, and some of this may be sex-based and some may be treatment-based. There was differences between males and females in terms of leg muscle and muscle quality. And abdominal fat distribution was intramuscular fat, which has a lot to do with, the core holding a person upright and core strength, was quite a difference between men and women, and that included visceral fat. So that tells me that we have a lot to learn in terms of optimizing that prehab, but also the post-treatment rehabilitation phase. So cerebellar testing, I don't know if anyone's tried that. It's not the easiest thing in the world, but neurologic testing can be challenging. So this is from the research robotics lab, rehab medicine, my collaborators there. And there's new technology. It will home in on the large joints and be able to give X, Y, and Z orientation. That way we can understand which muscles and nerves are affected. Again, neurotoxicity is a big issue with these treatments. And so with this cutting edge technology, in fact, it can even be done in your home. We would have the ability to really target rehab and identify, are we on the right track, and be able to make changes quickly. Okay. So future directions. I want to wrap this up by letting you know that the U of A is a unique collaborative and discovery environment. And you can see that research is from soup to nuts and many collaborative groups. I'm thinking identifying people who are at high risk for needing these high risk treatments and thinking about how can we offer routine prehab. We don't want your cancer to come back, but what if it did? We want you to be at your best. Cardiovascular disease is a competing death risk in hematologic cancer survivors. So from the learnings that we are starting to gather, can we identify personalized nutrition, exercise, pharmacologic interventions, and surveillance? And for everybody out there, you need to know, and you've seen, that oncology treatments are rapidly evolving. In fact, cancer care is the most exciting place to be. I can't imagine why anyone would want to be anywhere else. But also, half of all Canadians will have a cancer diagnosis at some point in their life. So that is something for everyone to be aware of. And because these are Alberta Wide Nursing Rounds, I want everyone to know that nurses and NPs are leaders, clinicians, researchers, and educators. And, honestly, if Nan were not part of the leadership team, much of the work that you didn't get to see today, but certainly this work wouldn't have happened. So I want to thank Nan and the hematology team for everything they do. Thank you.
That was amazing. I think we have to have you back. Putting it into perspective, the nurse on the ward, there's, when you say, 1 out of 2 patients are going to have cancer in their lifetime, we're all probably taking care of someone who's had it or who's going to have it. And I thought those assessments that Cecilia and Nan presented were actually quite brilliant in the sense that we should be doing it on anybody that comes in with a cancer diagnosis, wherever we're at. My one question I had was, are these patients, Nan, when you were talking about them, and I think it was Cecilia who said that you tell them where they should go if they have issues. Is it to the cross cancer emergency, like if you're in Edmonton, or like what if they're in, Bonnyville and start getting sick?
Yeah, so it's a really good point, right? Remember in the beginning, I said that they're required to live within 1 hour of the center. And so for up to 8 weeks, And so if it's after hours here at the Cross Cancer Institute, you would be directed to go only to the University of Alberta Hospital and no other hospital. If you're in Calgary, I'm assuming that you're being told similarly that you're going to the cancer center only. And before you even leave, before you get in the car, you're given the number for a CAR T pager, and that puts you in touch with the physician on call that week, who also helps then to alert the receiving center that there's an emergent patient coming in with CRS, and then to contact him for interventions. As I mentioned, the patients will, or as CJ mentioned, the patients will have a critical care flag, which is often overlooked on the Connect Care chart. It's in the upper left-hand corner. And it's important that we get in the habit of checking for those flags because, for example, the other day I was in a room with a patient who ended up becoming spontaneously violent, and it turned out there was a little note in their Connect Care. There's a little flag on their chart that said to be cautious with this particular patient. And it's something I had never been aware of before. So the distance issues are certainly a concern. And then the expertise is definitely also a concern. And then the financial toxicity to the patient who have had to move down here to be close to their care team is something that we need to work on.
Yeah, that's amazing. I love that term, the financial toxicity, because that's virtually all of our patients now. Not just oncology. When I think of the heart of patients. Are we because of the frequency and prevalence of this right now in our world, in the Alberta environment, of people on the wonderful new treatments, but also just with cancer, are we teaching it at all, Edie? Like cancer care for nurses?
Yeah, I think
Well,
it's
I think you should ask CJ. She just graduated from the program.
there we go.
How much cancer education did you get?
None.
Yeah, well, hey, I'm on the women's health thing, and it's the same thing, right?
Exactly.
Yeah.
Like, I wanted to be in cancer since I first started, and the only time that we were actually like taught about oncology was when we started to talk about end of life and essentially just palliative care. And so it just kind of like gets all these new nurses into this mindset that oncology equals palliative care. It's just one step away from hospice. They don't understand that our treatments have evolved in such a way that now we're able to prolong that, and we're actually having people with survival, and it's just people just don't get that, I think, because they're just saying, oh, oncology equals palliative care. So it is definitely lacking, at least for schooling for me. I don't know if it is different in different institutions, but that's just how it is for when
no, but that's what I was saying about following Edie, was that we say that in the women's heart health world that you're more likely to die, 6 times more likely to die of heart disease than breast cancer. And in fact, that was informed by knowing that we know now how to treat them. And it's chronic care, chronic disease management. And it sounds like the same here. And so even just talking about that immune system part would be really helpful for new nurses to know somewhere in their education. So that I'm going to go away with that and think about it, because we are starting to look at certificates for NPs, right? Like specific to women's health or maybe oncology care.
I just wanted to add as well, something that one of the nurses I was with for my first rotation in the outpatient department here and even on inpatients is that it's important to remember that cancer now is not a death sentence. A lot of patients, when they're new patients, like they come in here, they're like, oh my God, I have cancer. It's like, oh, actually, you need to think of cancer as a life-limiting disease. It's just, you don't know what's going to happen. You could pass away in a car accident before your cancer comes, or you could get cured before that. So it's just like having to change this entire perspective, because I think there's also the stigma, not just in nursing, but also just for the general public as well. And so I do think there just needs a general more awareness for everyone. So
yeah, even if we presented the successes, and there are many, but the other thing that I was going to say that always gets me is when someone says, oh, by such and such a year, we're going to cure cancer. And my question is always like, what kind of cancer are we talking? Because it's so distinct to the type of cancer. I mean, you guys have identified that today. and getting away from that mindset that these are.
And one of the things that we're talking about now is that you're going to die with your cancer,
Yeah.
not of your cancer.
Yeah.
Because we've made this into like diabetes. You treat the diabetes, but it's never going away. And so I have a whole group of patients with chronic leukemia who will never be off their treatment, never cured, but they're not going to die of their leukemia.
Yeah, no, and I really appreciated the slide you showed, or the study that you showed, where you were looking at the kind of the frailty of the people that are coming for treatment, because I think that's just huge. And it isn't that you're refusing treatment for them. They say you have to get stronger before you will survive this treatment, right? Like that's sort of the message. And we should be doing that on all
from diagnosis and from diagnosis.
Yeah. So really big, important lessons today. And I think, we will invite you back because we need to get more nurses on the line. I know we have wonderful oncology nurses on here. I'm sure we do. But I was just looking names that I recognize from the Faculty of Nursing, and we've got to really do this again. And we'll just really say we need to inform our care, across the province. So thank you very much for presenting, and honestly, the work you do, because to be able to change people's lives like that is pretty amazing. So thank you for that, and we'll be in touch to get you back. Oh, I need to mention, for anyone who's left, we are doing Alberta Wide Nursing Rounds is scheduled for Thursday, May 21st, and we're going to have PhD students presenting their work. Because I've been on about 4 dissertations lately, and I just think, wow, this is amazing stuff, but no one else is hearing about it. So that's our next one, Alberta Wide Nursing Rounds. So thank you very much, and we'll be in touch. Take care.
Take care, everybody.
Thank you
so much for having us.
Thank you for having us.
Thank you.